The stone-free status of patient has been extensively evaluated in the literature and also extensively discussed in the EU guidelines. That means no stone fragments on the postoperative imaging and a maximal 4 mm cutoff for eventual residual fragments. Now, in a recent publication, we assessed that the suction-capable accessories and endoscopes for flexible uteroscopic approaches have been used on an increasing scale. These are meant to lower the pilociliary pressure during the intrauterine procedures to increase safety and especially to prevent septic complications. They have the potential to improve visibility and small stone fragments clearance, thus improving efficacy. For the new scope from Pusen, the 9.2 French, numerous personalities have gathered together and shown its advantages, with Olivier Traxe and Bhaskar Somani on top of them. We had the privilege of experiencing in our surgical field all types of scopes. The 7.5 French without and then with suction, the 3.6 working channel, and the larger 9.2 French with a 5.1 working channel, and managed to promote our activities online and worldwide, because there are things to be said about this scope and the advantages it has in practical use. So we published that on numerous occasions in international congresses, also during the AUA, and have shown what difference it makes, the single-use 400A 9.2 French scope from Pusen. And the literature seems to agree with us. Here's a nice paper evaluating the intralineal pressure and suction performance, showing that the larger instruments being used during the procedure can cause greater impairment in flow, suction efficiency, and pressure dynamics. And these effects are less pronounced with a wider working channel, the 5.1. So the 9.2 French device in scope, a suction scope, offers superior flow and faster pressure dynamics. These are the main conclusions of one of our papers, that suction-capable accessories and endoscopes during flexible procedures have been used on an increasing scale. They manage to lower the pilociliary pressure during intrauterine procedures and improve safety, especially by preventing the septic complications. These instruments have the potential to improve visibility and small stone fragments clearance during intrauterine surgery, thus a better efficacy is obtained. However, the true practical impact of the medium long-term success rates remains to be determined. And these are a few features of the 9.2 French Pusen scope. Outer diameter 9.2 French, at the distal tip 6.8 French, the working channel 5.1 French, an excellent deflection of 275 degrees, the direct in-scope suction function that improves visualization by continuously clearing the field of view, single-use suction control for rapid activation, reduced intrarenal pressure, intrarenal temperature. These are great advantages during lithotripsy. It actively evacuates the stone, dust, and debris through the working channel, and that is designed for efficient fragment management and improved procedural safety. During retrograde intrarenal surgery, the issue of residual fragments has been extensively analyzed and debated. The EU guideline, as you can see, has established a threshold of 4 mm as being relatively acceptable. Now, there's gathering amount of data, including extensive studies, but also meta-analysis, that discusses the advantages of the suction techniques, and in particular, the device in suction scope technique. Although this is apparently easy, we have to realize that it may take some experience for the endocrinologist to regulate the three-way adapters and to perform laser lithotripsy simultaneously. The application of suction, either through the scope or through the X-ray sheet, requires an increased flow rate. This is we have to know. For the irrigation, larger than the conventional retrograde intrarenal surgery, as obviously fluid gets rapidly aspirated. As suction is applied, we take out dust along with blood clots, but there's also the danger of blocking the working channel. So the key to a successful aspiration is to have fine dust. during device in scope suction, and intermittent aspiration, thus with a low power suction, will help you keep the vision clear throughout the procedure, as we intend to show. This part of retrograde inner surgery has been described as a real game changer during the past few years, because several strong advantages have been proved: less residual stone fragments, a significant reduction in intervention, time of the procedure, associated complications, hospitalization, recurrency, and of course an improvement in quality of life. So suction should be viewed as an integrated system, leading towards the ideal flexible uteroscopy that's supposed to be anatomically flexible with good access, easy manipulation, excellent vision, and integrated energy system. These 5 items must be taken into consideration: the irrigation, the suction, the pressure control, most important, the blockage detection, and the automatic unblocking. So we may think of some conclusions that we try to outline in this paper, as endoscopic lithotripsy of kidney stones has revolutionized the minimally invasive management of urinary lithiasis. The last decade brought remarkable improvements regarding the miniaturization of instruments, the appearance of the single-use scopes, and the development of the suction methods, particularly targeted for residual fragments. The widespread use of the new single-use ureteroscopes with direct suction through the scope, combined with the new suction access, can significantly improve stone fragment rates. Of course, we need more randomized multi-center studies to standardize these findings. And this is just a quick reminder of the 7.5 single-use flexible scope from the Pusen. We've been using it for the past several years. It provides excellent surgeon control with built-in two-way tap for every device, a straight working channel with good access for the instruments, 285 degrees dual angulation, that's quite an advantage, dual light source that eliminates the shadows, blind spots, the hydrophilic coated shaft with a smooth insertion, outside diameter quite fit, 7.5 French, with excellent working channel of 3.6 French, 1.1 or 1-to-1 torque for superior maneuverability, a good HD processor for recordings, quality of image that's connect to the hospital system. It promotes the getting it right first concept, and with the standard and reverse deflection, it also has quite flexibility. So this is the case of a 64-year-old male patient with stone in the inferior calyx of 9.5 per 7.5 per 13.3 millimeters. So a calculated stone volume of close to 500 cubic millimeters, stone density of 580 Hounsfield units, and a negative urine culture. During the course of this procedure, we shall use the single-use flexible scope from Pusen 400A with a diameter of 9.2 French and a large working channel of 5.1 French, and of course device in suction. Also, what you may call classical or traditional access sheet from Boston Scientific or Cook 12 per 14 Sharia, the Polaris loop ureterical stent from Boston Scientific, and the Storz multi-lace TFL 60 watts the Quanta system. So dear colleagues, we are now returning with the second case using a Pusen scope. This is what we can call the relatively new kid on the block, the 9.2 French single-use flexible ureteroscope with a 5.1 French working channel. We've grown to really like this device. That's particularly useful. We have not found the real downsides in terms of maneuverability, but for the aspiration, the wider working channel provides some true evidence-based advantages. So when you're doing a more difficult case, a larger stone, when you are dusting a lot and you have a lot of debris that impairs your view, you really get to appreciate what the device in suction benefiting from a larger channel does. Now I know it's a tendency to become thinner and thinner for the scopes in general. But it's very important to remember that efficacy is the main parameter for any surgical procedure.
So this is why I will show you the effects of the 9.2 French from Pusen. We've been using it for about a year and a half now with excellent results. Some of them we've published in international meetings and also quite relevant papers. We're going to do dusting for a stone conglomerate in the inferior calyx. For the stone lithotripsy, we'll use a different laser now, the multi-laser TFL laser from Storz, and with a predetermined dusting mode that's already being set. So that will be 0.2 for energy, a frequency of 70 hertz, and the power of 14 watts. With energy of 0.2 joules. So let's begin. We shall now insert the scope. Let's open the irrigation, get the paddle closer, and connect the laser fiber. And let's enter the pilocalycell system. Okay, we're in the system. We'll also do a search. We'll always do complete evaluation of the all the calyces before actually starting lithotripsy, because it's easier. Visibility is excellent, so we shall take them one by one. Okay, we have a small blood clot here, but no fragments. And we shall move to the inferior calyx. And here are the stones, the stone conglomerate. You can see right here. So we shall first put in the laser fiber. So we also prefer to stay in the upright position with the scope during fiber insertion. This is important in order not to put pressure on the laser fiber. Theoretically, it's possible to do this also in some modified angle, but there's no reason to push the scope before the procedure and risk perforating the working channel. Although it is far more feasible than it is with the reusable scope. So we notice that in the terms of flexibility, it's quite important and quite a difference it makes the single-use scope. So now we shall move to the stone location, get as close as possible to the fragments. We have some movement of the patient, but like I said, this is unavoidable. We have the 150 microns fiber, and let's begin. Okay. Let's move to the second, a little bit higher power dusting mode, in order to get closer to the stones. Let's go. Okay, let's go. So we can see it's very important to be able to dust the rather smaller fragments. So these are fragments between 6 and 8 millimeters in total, but of course they can be considered stones, so not actually to be left behind, because there are always the danger, first of all, of stone recurrence and growth. As you know, these are the sources for the calculi in the evolution of the patient, but also in terms of upper tract blockage, so renal colic. So this is why the dusting part is tremendously important. And you know that the stone-free rate actually means 0 stones. As I mentioned to you before, That is a relative term. We know there are thresholds that have been discussed, 3, 4, 5 millimeters being taken into consideration, but the true zero stone means no fragment left behind. So for this particular calculi, you know, some years ago, what would you do? It would be difficult to actually perform this type of dusting and really fragment them, because there would be a lot of retropulsion. So what you would prefer to do is use the Dormia basket and take like 20 to 25 trips to take fragments out one by one. So that's time consuming. There's no guarantee that you will get them all out. So for all those reasons, let's do some aspiration now, because we have a lot of debris here. Okay. Okay. So we got everything we broke, and now we still have the fragments to lithotripsy. Less water, please. Okay. Okay, so we still have to do a very little bit here, because these are close to insignificant, but we want to really leave behind just dust. As you could see that the inferior calyx was completely cleared. Hold on, let me get closer a little bit. That's it. Okay. See, this is the last remaining fragment that's of a little bit higher dimension. It will completely vaporize, dust. This type of precision, you know, actually getting close to the fiber on a 4 or 5 millimeters fragment, actually see how you break it, the others as well. This is really great control. If you remember some years ago, this was not possible. So the progress in terms of vision, accuracy, and safety, and also laser control and efficacy, I think are quite impressive. And we've grown to accept and appreciate in our practice the fact that we see much better, we do a better job at lithotripsying the stones, and patient outcomes improve. And this has been noticed in the available literature, in the meta-analysis, in terms of quality of life, risk of reintervention, not to mention recurrent urinary tract infections, because you have one scope per patient with no re-sterilization process. Also in terms of cost efficiency, if you only think of the terror that you would break a reusable scope and pay for the repair, which means most of the times replacing the flexible part. So in all aspects, I think that the technological progress has really, really helped. So you can see how the fine dust is being created. This is not an easy case, because, you know, theoretically, when you go by the book and you look at most of the presentations available on webinars and during the main congresses, for smaller stones, such as this case, stone conglomerates, group of stones, it's not easy to do dusting. The idea of dusting is to have one stone that you approach bit by bit from the surface to the interior and just break it to have really fine dust. For this one, for these conglomerates, we had to break like every fragment in several pieces. As you can see here, I'm trying to get as close, but this is tremendously magnified. So what you see, these small fragments here, they can be spontaneously eliminated without any problem. Patient was also pre-stented, as most of our cases are. But what we do is we give the very best chance possible in the available treatment means today to have the patient truly storm-free. Let's go again here. The main key to the procedure is patience. You know, you really have to take your time. There's no hurry. Things is going well. No bleeding. Very nice image. The fragments keep getting smaller and smaller to get to the real dusting part. Like I said, it's not the ideal case because this is multiple lithiasis. I would have loved to have a case like the one before, but then again, we have to show all aspects of practice. I think it's only fair because you will not get only one single stone that you control from the very beginning, that you stay on the surface, and that you get the dust from the very beginning. Some cases you have like this, and you know you have to adapt your technique to the patient and not the other way around. So this is what we do. Okay, let's do some aspiration now. Okay. Great. So I think we're very close to finishing. This is very little debris here that we will do some final lithotripsy, and then we're pretty much done. Because as you can see, these are the fiber is 150 microns, and these are pretty much the diameter of the fiber. So let's go. Okay, let's go.
Regarding the size, you can compare with laser fiber. Laser fiber, it's around 150. Oh, it's less. So 150 microns. You imagine the fragments. It's very close to this dimension. I mean, maybe 200, 250 microns is exactly, that is written. It was written recently, the real definition of the stone-free. I mean, less than 250 microns. So this technology, look here, it's quite good, and you can see exactly the fragments. Very good the fragmenting, because in the beginning the stones were in the inferior calyx, so very difficult situation to treat inside the stones. But look what is aspiration. I mean suction with this great telescope.
Okay, so I think we did pretty much all that was necessary in this case. I think we're stone free. Very little debris. You can see here. This is, I think this is the desired outcome for just any calculus, including the multiple ones, which, like I said, are a little bit more challenging. So these are the final stage. This is the final stage of the aspiration, in which we take out the last debris from the pylocalicial system. So it's been a pleasure. I think it's a good example of daily practice. Daily practice is not perfect in case of in the terms of case selection. You will have multiple lithiases. You have combined smaller and larger fragments, and you have to adapt your technique and keep it feasible for all types of stones. And for all the above, I think the 9.2 French from Pusen is an excellent solution that combines flexibility, maneuverability with excellent therapeutic efficacy.
So this is the case of a 32 years old male patient with one stone in size 9 per 8 per about 7 millimeters. So total stone volume of 233 cubic millimeters, a stone density of 1,200 Housefield units, and a negative urine culture. During the course of the procedure, you shall use the single-use flexible ureteroscope from Pusen with a 7.5 French caliber, a 3.6 French working channel, and suction. Also, we shall use a classical or traditional, if you want to call it, access sheet without suction from Boston Scientific or Cook of 10 or to 12 Sharia. Also, the Polaris loop ureteral stent from Boston Scientific, and for the laser lithotripsy, the Cyber HO laser generator Magneto, the Quanta system.
So, dear friends, it's a great pleasure to be with you today and share part of our experience with ureteroscope that's very dear to us. That's the 7.5 French scope from Pusen. We have been using it extensively in our experience over the past few years with very good results. The device in suction gives us a great advantage, as I will show you throughout the procedure. We'll be using the 10 to 12 Sharia access sheet from Cook, and also very efficient laser that we highly appreciate, the Magneto Cyber HO 100 watts from Quanta system with predefined dusting mode of 8.4 joules, 8.4 watts, 0.7 joules and 12 hertz. That is specifically designed for this type of lithotripsy. We have to keep in mind that dusting is an extremely important part of this procedure, because it enables you to optimize the suction through the working channel. This is a thin, very maneuverable, excellent accessibility ureteroscope, but the working channel of 3.6 French imposes a very good fine dusting in order to really benefit from the suction process. Okay, so we shall begin the procedure. The access sheet is already in place. The water is running, so we shall see where we're at. Okay, so we're in the kidney now. The stone is in the inferior calyx, but we shall do an inspection of all the calyceal cavities, just to make sure that there are no other fragments left behind. The patient was pre-stented, so the access by access sheet was quite easy. Now there's a lot of debate going on in the international meetings about the eventual, there's the calculus, there is, okay, about the usefulness of pre-stenting. And there are opinions, pros and cons. Let's put the fiber in, please. So there are opinions, pros and cons about this topic. Our experience is that in the greatest majority of cases, having a double G stent before the procedure facilitates the access and almost guarantees being able to use the access sheet. The access sheet is tremendously important in terms of irrigation and vision, and therefore we are strongly convinced that this facilitates the various technical steps of the procedure. I know there are numerous reports about sheetless procedures. I'm sure that's possible. In our clinical setup, and especially when you're doing a hard case, a difficult stone, a large stone in a difficult location, but also as a general rule, with the access sheet you have complete control over visibility, over irrigation, and therefore pressure and temperature control. Okay. So we're in the calyx, we have the laser fiber in place. We're gonna go as close to the stone as possible, and we shall begin the procedure. As you can see, I tried to move as much as possible around the surface. Okay. Of course, there are the movements of the patient which obviously do not help us, but they're somehow unavoidable. Okay. The idea is to remain on the surface and break the stone gradually, and to avoid, of course, as much as possible, when possible, the production of big fragments. Going to the very core of the stone and breaking in half clearly will not improve your stone free rate, okay? So the dusting mode means having a little bit of patience. That's important. I think it's important in any urological procedure, but for benefiting from the suction, I think this can be a real threshold. So as you can see, I'm tearing up the surface of the stone. Oh, sorry, let's go. Most importantly is to leave the patient stone free, because you know there's a lot of debate about what stone free really means. And stone free means 100% success rate if you do not perform post-operative imaging. And if you perform a relatively positively sinking ultrasound, then you can keep your 100% stone free rate. But if you do some real imaging, and by that I mean native CT, which is standard and it's not expensive, it's easy, it's fast, then you get to notice that you're not as stone free as you would have imagined. So in order to really have stone free and to really make sure that you have stone free, you need to keep in mind that the post-operative control is extremely important, and the CT will tell you the truth, whether or not there are still the remaining fragments in the kidney.
You know, I have to add some very important thing. Look to the movement of the fiber. You know, this is sometimes it's you know, you need a very trained team, because usually you fix the fiber and you move the flexible radiologoscope. But here you can see, because the stone is in inferior calyx, it's real quite difficult to treat this position. But using this tip and tricks, you can see perfectly how it works. It's great. And the laser, look to the absolutely amazing laser fragmenting and dusting of the stone.
Also, I appreciate very much the magneto for optimizing retropulsion. As you can see, we stay in good contact with the stone, and the fragment does not run away from us. And I think this is a very important progress, because it keeps you right in the action and minimizes the dead times, the times when you're not able to do laser because you have to chase a stone. And that can really impact your surgical duration and diminish your efficacy. So I think we're doing quite well here, getting rid of all that. And since we're producing a lot of fragments, we should do some suction. So let's close the water, please, and use the suction pump. Okay. What I will go in this area where you can see all the fragments. Okay. And now we're clearing up the view. Okay, so you can see. Okay, so this should be enough for now. So at some stage of the procedure, once you gather a larger amount of dust, this can really help you clear out the image. Okay, so let's go on. You can see that the dusting works also for smaller fragments. So the idea that if a fragment of a few millimeters got away, it means you can no longer do dusting with the magneto. That's possible. You can still do dusting. Just to make sure that these fragments you'll be able to aspire in the end. Okay, so let's return to the main stone. Okay. Perfect. Even for the small ones, go.
What is very impressive, if you look to this operation, is the performances of magneto.
Okay. Look, turn to the stone.
Yeah. No retropulsion. This is unbelievable.
Okay.
So you have to know that now we are in the inferior calyx. So it's quite in situ surgery.
The advantage of the inferior calyx is that the fragments have no place to go. So you can finish your lithotripsy very locally, so to speak. Of course, there's always the choice of basket relocation that has also been discussed in several studies. And for really acute angles and narrow infundibulum, that could be the solution. Yes. So now we shall move to the second dusting mode that really increases a little bit power. And you can see practically vaporizes the smaller fragments. Well, they were small enough for spontaneous passage, but we want to be perfect in terms of stone free rate. And you can see that this is pretty much a reality. Okay, let's do it here too. We still have some very small but still visible fragments. Okay. And here.
this is a special mode. It's 14 watts now, 14 watts, 0.7 joule and 20 hertz. A little bit, the power is a little bit higher, but look the efficiency. It's also dusting, but it's a special dusting from Magneto, special dusting.
So you can see that the fragments are growing quite insignificant, and we shall use another suction moment now to take out what's left of the debris. Of course, this was not a very big stone, but for stones of 2 to 3 centimeters, that can be quite useful, because the idea is to prolong your procedure and see well during the long and difficult stages of lithotripsy. Right. Okay. Let's add some water. Okay, so what we'll do, just a little bit more here, and we're very close to the end. Let's go. Okay, so pretty much done, because this looks very clean. This you won't see, not even on CT, perhaps 1-2 millimeters. We shall do one final aspiration here, and as you can see, the inferior calyx has been cleared from stone, from a 1 centimeter stone. So that went really fast and efficient. And now we're taking out what's left of the debris, because these very small fragments could be, as it has been shown also in the guideline, the source for future stone recurrences, right? Okay? So I think this is very, very nice. So at the end of the procedure, we won't even need a double G stent, because there are no fragments that could actually block the ureter in the next days. So thank you very much for your attention, and we shall see each other again on the 9.2 French from Pusen scope.